All right. Thank you all for sticking with me. I apologize for the late start here. I am Jan with PCC. I work with the Pediatric Solutions Consulting team, and this month is one of a series of web labs that we do almost every month to keep everybody up to date on billing, coding, and practice management topics that we know are relevant to you all, and to give you guys an opportunity to talk with one another. So things are slightly abbreviated. I've got everything but the last couple chapters of the ICD 10 updates for this, for the upcoming ICD year, which begins on October 1st. But we've also got some, I'm kind of bringing things up to current. There were a couple of months that we did not have web labs in favor of hosting our very first ever virtual users conference. So we've got materials for you related to that, but that explains why we haven't had one of these web labs in a bit. But we'll go over, I'll share a link. I'll share PDF of these slides with you immediately after the presentation today. They will go, I will share them with our education team, and they will go up on learn.pcc.com in the typical spot. So we'll have some recent updates to codes, as well as a spot for you in that PDF to get to the UC materials. I'll go over some of the UC, no, not UC, I've got UC on the brain, some of the ICD 10 2021 updates. I'll bring you up to current in the table of contents, at least, just a high level view of what was covered in the AAP Coding Newsletters in the intervening months where we had no web labs. I will go over some highlights of the version 8.13 PC software release that will happen this Sunday. And then we will open up the phone to a billing roundtable, so you can ask your billing questions of one another. So getting on into it, when you get the PDF, these blue links right here will bring you to more information about these items. The users conference was held over a series of weeks in May and June this year. We were attempting to capitalize, to make the timing work for the greatest number of people. It's the very first time we've recorded all of the sessions. And though we did not get enough notice out for everybody's taste, we did record everything. So some folks were able to attend live performances, that's the wrong word, live events of each of the slides, and where there was live Q&A, and we had some chatting and networking in a wholly separate chat feature. But these all went up on YouTube. They are on PCC's UC channel, and the slides and recordings are all available for folks that either were not able to make any of the live events, or if you just want to revisit one or recommend one to someone that couldn't be there. That second blue link there for S8301 is, and this is not an update as such, but it is news. There has been some information shared among and around clients recently that some pediatricians are being paid for PPE. So if you think back to UC and earlier, we were recommending that 99070 be something that folks try billing for, to get payment for the new and unexpected expensive PPE supplies, your gowns, your booties, your face masks, all the things that you now have to use in light of COVID, where you didn't have to before. This is new expenses. So we were hopeful that carriers would accept this new use of 99070. It is a non-specific materials code, but we've gotten a tip recently that there is a HCPCS code that some carriers are in fact paying for. So whether they're conscious of it or it's simply one of those that didn't make it into their edit exclusions, the HCPCS code S as in Stephen 8301 has a description of infection control supplies not otherwise specified. And if that doesn't describe PPE, I don't know what does. So similarly to however you priced the 99070, if you are billing for that currently, I would recommend pricing it similarly if you have not changed the way that you've used for the kits, the components that comprise your PPE kits. You can use this. I would price it similarly, identically, if you have not had any changes in that supply configuration. And I recommend giving it a shot. The good news is that people are reporting that this is for sure being paid. So that's a nice change from the 99070, which many people have been billing for months now and simply don't have payment for, have not gotten any payment for. And again, this is Jan Blanchard, the broken record. Bill it whether you get paid or not. Be sure that you're billing either of these codes for the outlay that you all are suffering in this new cost for rendering care and keeping everybody safe while you're doing it. There is an older code that has been in use, but it's still news that one of the recent updates, one of the recent CPT updates indicates that you've got 87635 is a code that is used for some of the in-office COVID-19 testing. Make sure before you use this that whatever testing you're doing in your office matches this description. So be sure that it's the DNA or RNA detection and that it's for COVID-19 specifically, the amplified probe technique. This code, I mention it today because this is the first webinar we've done since mid-March that noted this. The code was effective 3/13, but CPT will publish it. It'll be part of the paper manual and the official manual for the CPT 2021 edition. There's also, this blue link here is a good guide that is online to the LOINC codes that match the COVID testing kits that have been developed. So in addition to the CPT codes that have to be reported, if you're using PCC EHR, you know that you, in order to make proper use of the laboratory component, the lab orders and results, you need a corresponding LOINC code to identify it and for purposes of receiving results, and in some cases for printing or sending lab requisitions. There are changes also to the CPT-1. One of the recent changes, the July changes, includes CPT-1 code updates that detailed the removal of the FDA approved pending lightning bolt that you guys are used to seeing in your CPT manual. It's at the bottom of the page and talks all about, or it indicates when a vaccine, or really any code, if any of the codes, services that are described by a code require FDA approval, you'll see a lightning bolt next to that code if its publication in CPT predates or precedes the FDA approval. So if they're on track for approval, but it has not yet happened, the code can get into the manual, but it's going to have that little lightning bolt. And this is just the closing of that loop. When these are approved, when such services are approved by the FDA, then CPT goes through and removes that lightning bolt. So beginning with the 2021, you should see the FDA approval lightning bolt, that pending lightning bolt, disappear from these specific vaccines. There is also a bit of news that I wanted to share with you from CMS. And again, CMS, as go CMS, often go the other payers. Recently, CMS announced that they are making payment available to Medicare providers when they render
You guys join by phone. Go on the bottom.
When counseling is rendered for visits that are related specifically to COVID counseling, COVID testing counseling. So what they're saying is you can bill an E&M code. Medicare will now pay E&M services when they are billed for the purpose, even just for the sole purpose of counseling for COVID testing. So it is a possibility that other carriers will follow suit. What you have to be sure to document, if you're following Medicare guidelines, you want to be certain that you document these bullet points here. And the blue link at the bottom here, the top link is just the article, the announcement, the press release from CMS. The bottom link there is the checklist that CMS shared, and it basically just consists of these bullet points. So if you just want a prettier or more official looking version of it, you can use that link at the bottom. But you need to be certain that counseling that you're rendering or that you're offering your patients includes all of these bullet points. So you have to discuss the need for immediate isolation. So this is when the patient comes in for testing. It's on that testing encounter. So what your clinicians are basically doing is explaining to the patient the expectations and the effects of testing. So making sure that they know the very fact that they're being tested assumes that they have either had exposure or they have symptoms. There's some reason for the screening. You need to be sure that the patient understands that immediate isolation is important even before the results are available. So just making sure the patient understands, just because you've been tested doesn't mean that you're in the clear. There's that all important time between testing and receiving results, when you can determine whether your expectation is that you're infectious or whether it's safe for you to spend time with other folks in close quarters. When testing, recommending that patients should inform their contacts that they may wish to be tested, and if you've got reason to believe that they do have COVID. So even in advance of results, counseling how they should behave, treatment, not treatment, but reference to contacts, their contact tracing light, I guess you'd call it, and just warn the people that you've been around. Going through a review with the patient of where they've been, helping them understand the importance of and the relevance, the involvement of locations and contacts. Review with them what the actual signs and symptoms of COVID-19 are. Make sure that they are properly informed about what is expected, what the typical or expected symptoms are, and let them know that if they're positive, they will likely be contacted by a public health worker. So that contact tracing we're all hearing about, that is initiated by public health agencies, and letting patients know that they can expect that, and that and also encourage them, as they mentioned here, to answer the call. Make sure that you're not blocking all those unknown numbers like many of us tend to do with caller ID. And also discuss services with the patient that might help them successfully isolate and quarantine. So whether it's delivery services or in-home care, safe in-home care, any resources available in your area that could help a patient remain at home and observe take your advice to quarantine and to successfully avoid exposing other folks in their life to the virus until they're certain, or even after they have been diagnosed. So that's that possibility. I'm kind of excited about that. It was nice to see that Medicare is making that concession and making payment for the time-consuming testing, counseling you guys are doing. So hopefully, again, that was E&M. I don't know that I made that explicit, that E&M codes are what Medicare is paying for this kind of counseling. It's not anything special. They're simply seeing the need for it, they're recognizing the need and coming through with payment for it. On to ICD-10. So every year around this time, I start looking for the files from CDC that include all of the updates to the ICD-10 code set. And if you recall, October 1st is the effective date. October 1st every year is when the new ICD-10s go into effect. So we call it the 2021 ICD-10 year. All of the last 3 months worth of services each calendar year are expected to adhere to and make use of the next year's 2021, in this case, the next year's ICD-10 code set. So the 3 links that you see here are free versions of the index, the tabular, and the external cause codes. And those are the 3 things that are most frequently used when I'm assisting with ICD coding in outpatient pediatrics. So each of these links, like I said, is a free version. It's a PDF. They can be pretty large. Can be is not even an option. They are very large. The external causes one, not as much, but if you think about it, the index and the tabular, they both include 100% of all of the ICD-10s. So with the explosion from 9 to 10 in laterality and greater specificity, chronic nature, acute status, those things, these are big files. So be prepared. If you've got a poor internet connection, you might hog all the bandwidth getting this one onto your computer. And I would be remiss if I did not repeat the advice that when you're looking for a new code, if you are in search of a code for a condition that you've either never treated before or never billed for before, the order is always to start with the index. So I put these in this order for a reason. If you're looking for a new code, you start with the index, find that in the alphabetic. The index is arranged alphabetically. Find the condition you're looking for in the index. That will show you a code that you then go into the tabular to look up. So you find your code in the index based on the condition, take that code to the tabular, find that in alphanumeric order, and then you'll see the variety of guidance. You'll hear me use the word guidance a lot in the presentation today. That's the excludes all of that information and direction that you're given in these tabular sections. And these will make sense if you're unfamiliar with those as we start to go through the changes that will take effect October 1st. Before we get into those specifically, there is a full file list here at the blue link on this slide. And what that does is it shows you every possible ICD-10 list used in the US. Not all of them are appropriate to outpatient services. There's a whole host of ICD codes that are what are called POA exemptions, and those are present on admission. That's 100% inpatient and facility coding. So you can ignore all the POA files, but you're also, the things in addition to the other three files that I just mentioned, the index, the tabular, and the external causes, there are two others that you may come in contact with, or you may find you have need for. And I don't know that I've ever covered those before. So I wanted just to do a cursory review of the table of drugs and chemicals and the table of neoplasms. This is an example of what the table of drugs and chemicals looks like. It is listed in alphabetical order, and I grabbed the warfarin example simply because it had some indents, and I could explain some of the taxonomy and the hierarchy, the way the table is laid out. The intended use of this table is for you to identify exactly the very specific code that you need when the condition that you're treating is related to a patient's interaction with a substance. So you can see the variety of interactions across the top there. There's poisoning from left to right. Poisoning accidental, meaning unintentional. There's poisoning intentional, meaning self-harm. So those first two columns assume the patient is the actor in this case. Poisoning by assault is that middle column there, and that's when someone administers to them, and it is intentional. So you can see the growing list of factors here. It's whether they were poisoned, whether it was intentional, who was administering the drug or in control of the substance, because it's not all drugs, it's drugs and chemicals, as you can see. And whether there are also two columns that will help you identify codes for adverse effect and underdosing. So in the event that it's not a poisoning at all, it is an intended use, but that the patient suffers an adverse effect, you find this laid out this way so that your coding can be done based on chemical or substance. So this is just a different way of laying out codes that you find in your index and tabular. It's an easier way of looking at it for some people. And then underdosing, I don't think I put word to that final column there, underdosing. So if it's an intended use, but the patient's not reached a therapeutic dose of it or hasn't had enough of it to have the intended effect, that final column on the right there is the code for you. The other reason that I chose this example is just to illustrate the variety of substances. So it's, as I said, it's not just drugs, but it's also some drugs that have other uses. So warfarin is a rodenticide. So it may be the same substance, but it is meaningful from a coding perspective, whether it was the warfarin drug or the warfarin rodenticide. So, mouse, rat, poison, that kind of thing. As well as substance, also including things like wasp stings. I could have picked an easier one to say, I guess. So wasp stings. The adverse effect and the underdosing you see for the rodenticide and the wasp stings are excluded. It's simply not a logical use of this table. You wouldn't have someone prescribed rat poison. So the adverse effect of rodenticide is expected. So poisoning is the only set of selections for rodenticide in human medicine. So that's the table of drugs and chemicals. There is a similar looking table, but with a very different approach and very different purpose. hopefully there are not a lot of patients, but I know they exist. Hopefully there are not a lot of patients in your practice for whom you need to get to this level of coding. But in the case that you do, you've got a good layout here of the information that you need to properly choose neoplasm codes. So the selection of what body area and body feature, which parts of the body. And then similar to the other table, you've got a handful of columns that are all dependent on the way that you mean the code, the way that the patient presents, the nature of their condition. So in neoplasms, we speak in terms of malignancy and behavior. So when those things are determined, you've got a good set of columns and rows here that are going to help you zero in on the exact perfect code to describe the body site and the exact type of neoplasm you need to code for it. Again, a little bit out in coding land, but having never covered it before, I wanted to be sure I gave at least some cursory familiarity to you with it. And on to the changes. Bear with me a second here while I mute everybody again. As people arrive, they arrive unmuted, and I've got to spend time muting. So, as I said, as I've promised, moving on to the beginning of the 2021 ICD changes. The tabular addenda is yet another file. So this is a different link from the others earlier in the slides, where you want them. You want to be sure that you are looking at a condensed version. When you download this, I'll give you the cutting and pasting that I did to create these slides looks very much like the entries that are in the tabular. The difference is that in the margin, the left margin is where you're going to see where things have been added, deleted, revised, that sort of thing. So if you do go to this link and download this tabular addenda, it's going to look very much like the tabular, but don't be fooled. Look for those edit mentions in the left margin, and it's going to be much, much shorter. I think this one is only about 56 pages of changes. So that's why I try to go through these and narrow it down for you and draw your attention to the ones that I think are going to be most useful. So chapter by chapter, here we go. Buckle in. In the certain infectious and parasitic diseases chapter, otherwise known as chapter 1, there is a reference to COVID-19. So most everyone is probably aware that when a patient is infected with COVID-19, U07.1 is the new code that was introduced earlier this year to represent that infection. There had already been in existence coronavirus infection unspecified. So we'd offered advice and guidance earlier this year to say, when they're infected and you know it has been identified, it has for sure been identified as COVID-19, use the U071, do not use the B34.2. When you say unspecified, you're indicating that you don't know what virus. You know it is a coronavirus, but you don't know which coronavirus, and that is not the case when they've had a positive COVID test. So logically, B34.2 now excludes 1 guidance, which means these codes should never be billed together. So in a case where you have both of those in place, you're going to want to do a bit of digging, confirmation, make sure whether it is for sure COVID-19, and select the appropriate code based upon that. Chapter 1 also had an explosion of babesiosis codes, unspecified and due to a variety of different organisms. So that got my curiosity up, and I was looking around to see if there had maybe been an outbreak of babesiosis. There's typically an uptick in cases of a disease or instances of a type of injury before new additions are made to ICD-10 like this. I found an uptick in cases this is a tick-borne disease. I found an uptick, so that's probably why I'm using the word uptick, in cases in the UK, but I did not see anything here in the US, and I hope it stays that way. But these are the new codes that can be used to describe the differences when we get to the point where we know specifically which babesiosis organism it is. Once that level of identification is done, you can choose between these. When you don't know, the B60.00 before you have test results is perfectly reasonable. And if you do get test results and it's not one of these microorganisms or organisms, B6 0.09, other babesiosis is what would make sense. In chapter 2, the neoplasm chapter, there are a bunch of punctuation changes, and often I'll characterize these changes by chapter just so you understand why there's a volume of them. I take my time looking through these and comparing line by line to be sure that I'm not overlooking something important. There were a bunch of punctuation changes in this chapter that amounted to very little. There were a lot of guidance changes where an excludes one went from having a dash at the end of it to having a period at the end of it. So there were not material changes. It didn't affect the way that you would use a code. It didn't affect the application of the guidance, other than to possibly lead you to, when the dash is at the end, you look for maybe another code that might be more specific. But for neoplasms for outpatient primary care pediatrics, I wasn't going to spend a whole lot of your time on it. There was one code also added to the code C93.1, chronic myelomonocytic leukemia. I had mentioned in a recent ICD update, there had been sort of an out-of-pocket update done, eosinophilia, I don't know if I'm pronouncing that properly. There was an explosion of those codes, I want to say probably last October. And now this is a logical follow-through on that. Because those eosinophilia codes had become available, a lot of the guidance that included, or rather the guidance for diseases that are related to it, would then be updated to include that D7218 or any of the new codes from last year. So again, many of these changes in these 56 pages have to do with just closing loops and bringing codes that were introduced last year into the guidance that they relate to, or new conditions where new codes also are part of that guidance. So that's what's going on mostly in chapter 2 this year. In chapter 3, diseases of the blood and blood-forming organs, as well as diseases and disorders involving the immune mechanism, there were many updates and additions. And because they are going to be very specific to the patients that you're treating, I didn't detail all of these. Like I said, there were pages and pages of each. So if you've got patients with sickle cell disorder, aplastic and other anemias, eosinophilia, and other immunodeficiencies, there are a whole lot of updates to that. And again, the value that I can add to this falls away when it just ends up being pages and pages and pages of the same thing with lots of variations. These are specific enough that your clinicians are going to be the best people to tell you whether the specificity that's added to these sickle cell disorders and anemias and such are meaningful for your patients. So I definitely recommend, if you do download that tabular addenda, if it's only chapter 3 that you put in front of your clinicians, ask them just to quickly give that an eyeball and see if anything stands out to them that looks like something that should be linked. Again, this is your ICD-10s, so find out from them if they think there are any SNOMEDs that they frequently use, or if they have a patient in mind that they know that they're going to need those for, so that you can link them and have that ready for them ahead of time. Chapter 4, endocrine, nutritional, and metabolic disease. There are very few additions to this, one of which I think was relevant: disorders of glucose transport, not elsewhere classified. I don't know how relevant it is, but it was a very, very short chapter of additions. So it was easy to say protein 1 type deficiency, other disorders of glucose transport, or unspecified. Those were the 3 additions to E74.81. And one other addition, there's that new code, other specified disorders of carbohydrate metabolism. Chapter 5, mental, behavioral, and neurodevelopmental. So there is a layer of specificity that's been added to substance abuse, the substance abuse codes that are listed on this slide. Specifically, the alcohol and opioid abuse with withdrawal had added to them whether they were complicated and whether withdrawal delirium was included, whether perceptual disturbance was a factor, And then, of course, there's always the good old standby unspecified. So if your practice is seeing has a population of patients who are diagnosed with abuse disorders, withdrawal, and these surrounding factors, these complications and these side effects of withdrawal can now be coded specifically. So again, each one of these 6 codes, the F10, F11, F12, those all are broken out with different varieties of those 4 layers of specificity or those additional factors. So specifically, if you've got clinicians that include in their record that delirium or perceptual disturbance are part of what the patient presents with or has experienced, then you do have options for those. That greater specificity is now available, or will be for services October 1 and beyond. There we go. In Chapter 6, diseases of the nervous system. So the changes that we're highlighting, in my estimation, in this chapter, all relate to a new code in another chapter. And what I mean by that is the excludes guidance for migraine, for other headache syndromes, and for pain not elsewhere classified now have excludes. There's a new headache code that I'll cover when we go over the R chapter. But the only changes to those, migraine itself hadn't changed. Other headache syndromes hadn't changed. Pain not elsewhere classified is still pain not elsewhere classified, but those 3 all now have excludes 1 guidance that is headache NOS with the new code R51.9. Chapter 6 also, it has a whole new set of CNS fluid leak codes. So because newborns, there are some newborn codes that address this sort of thing for patients with neural tube defects and that sort of thing. But for the variety of causes of cerebrospinal fluid leak, you've got now a good variety of codes that can specifically address those. So whether it's spontaneous, whether it's cranial or spinal, whether there of course is the perineural cyst thrown in there in the middle, and then disorders of meninges available. There's also an addition of intracranial hypotension is a brand new code. That code was also propagated as a code also throughout a lot of neurologic ICDs. So if hypotension is a factor or a possibility and is assessed and described in a chart that you're coding for or a code that you're looking for, that intracranial hypotension is now something that can be coded specifically on its own, as well as coding also to the related conditions. Diseases of the eye and adnexa. Eye movement were the focus of the big changes that I saw this time around. You've got, in addition to a full page, more than a full page of hereditary corneal dystrophy codes. If that's a condition you guys see, or you've got a ophthalmology sub-specialist in your practice, that may be relevant for you guys. But the H18.5 section is huge. It's a huge new addition. But the H55.8 irregular eye movements, and I know that that's something that is screened for often enough that I thought this was worth mentioning. I don't know that the screenings, I'm pretty certain the screenings don't get to this degree, but if a clinician were to observe this on presentation, might be coding for these deficient eye, I don't know how to pronounce saccadic eye movements, deficient saccadic eye movements. It went from being just saccadic to being deficient. So you've got the 2020 version there, and it became, so this is a revision. This is not a brand new code, but a revision of the H5581. The new code is H5582, and that is for deficient smooth pursuit eye movements. So depending on how the patient presents, you choose one or the other. Chapter 8 had 0 changes. I couldn't escape the feeling that I was adding one of those, this page left blank for a reason type slides. But for the sake of completeness, I wanted to be sure that I got everything through to you, and there were just 0 changes. Chapter 9, on the other hand, had the circulatory system tends to be mostly packed with adult medicine ICDs, but in this one case, because the excludes is a new part of guidance for cerebral infarct, they are specifically excluding neonatal cerebral infarct because the P91.82 codes are new. And you'll see that when we cover the P chapter later on. There are lots of guidance changes for a whole host of atherosclerosis. And again, those aren't often pediatric conditions, but there are always exceptions. So if that's something that there are folks in your practice that patients in your practice suffer from, be sure that you're aware of those changes in the I-70 section. In the J chapter, diseases of the respiratory system, the excludes 1, influenza virus with other respiratory manifestations, has been added to the guidance for all 3 of these conditions: acute pharyngitis, acute tonsillitis, and acute upper respiratory infections of multiple and unspecified sites. When you think about it, that makes a whole lot of sense. When we talk about coding for diseases and excluding the symptoms from those, these make sense. So if you're looking at a patient that is positive for influenza virus with other respiratory manifestations, these codes below, codes that are excluding, are mutually exclusive with that, are acute pharyngitis, acute tonsillitis, acute respiratory infections of multiple and unspecified sites. If you've got flu with respiratory manifestations, it stands to reason you wouldn't also code the symptoms of those manifestations. And I'm getting reports that the sound stopped working for one person. Are there, if folks that are able to get to the chat can let me know that that you're still hearing me, we can sure that I'm not shouting into the void here. If anybody could just chat yes into the, now it's working. Okay, so that person, a resolve for that person. Thank you for letting me know. I'd always prefer to have it keep flowing than to think that I'm recording something useful for you guys, only to have to go back and do it all again and waste your time. Chapter 10, code also, oh, I think this is a continuation. Yeah, chapter 10, diseases of the respiratory system. So as I was saying, it just makes sense. All that these excludes changes do are reiterate what we already know. You do not code for symptoms when you've coded for the disease. And there is another code also, a bit of code also guidance. Influenza if present, such as novel influenza A, other identified influenza, and unidentified influenza, that guidance is added to the acute laryngitis and tracheitis and acute obstructive laryngitis. So add that code also advice to both of these, the J04 and J05. Those are new additions to the coding guidance for the J04 and J05 beginning in October. Continuing chapter 10, J10, influenza due to other identified influenza virus, now explicitly includes flu A, flu B, and flu C. And the flu A is specified as being non-novel. So the also known as, or the otherwise known as phrase for J10 now includes these 3 organisms. It is now explicitly stated and understood. The advice for asthma now advises the use of that J82.83 that I mentioned earlier, that new code. I'm sorry, I'm mixing up the eosinophilia codes. This is eosinophilic asthma, which is a new code this year, J82.83, that is included now in guidance for asthma J45. So plain old asthma should also use J82.83 when that's a factor. And there is all kinds, if you use the J82 or J84, those are the pulmonary eosinophilia and other interstitial pulmonary diseases. If those are codes that you know are used in your practice, do yourself a favor, familiarize yourself with the guidance rearrangements. There have been changes from excludes 1 to excludes 2. I could try to describe them, and I thought about it. I put together a handful of slides and then ended up deleting them. They were more confusing than clarifying. And if you don't use these codes, I was spending time on something that might have just spun your eyeballs in any case. So this is one of those cases where it's much, much more meaningful, I think, to look at the changes and to consult them when you use the code than it is for me to try to speak about them. They were numerous enough and complicated enough, and I'm more than happy to walk anybody through them individually if you use these codes. I'm not trying to get out of doing the work on this, but this just wasn't a good, clear way to communicate those changes. Chapter 11, diseases of the digestive system. The K20.80, other esophagitis, these new codes, this entire slide is all brand new codes. So esophagitis is being coded unto itself now. So the options for it, or the possible presentations that can be coded, are with and without bleeding for unspecified and other. Not super specific yet, but more specific than before. So these are brand new codes for your use. GERD with esophagitis without bleeding and with bleeding is also now available. Another new code is Ogilvie syndrome. I've not yet researched that. I don't know for sure, but because it was here in GERD, I see that often enough in the records that you all make and the ones that I audit. So I wanted to be sure, even if tangentially related, that you have a good understanding of these new K21 codes. And other specified functional intestinal disorders. So if atony of colon and pseudoobstruction are things that you have seen in your practice but have not been able to code specifically up till now, now you may, beginning in October. Chapter 12, skin and subcutaneous tissue. The only changes that looked material to me were to the guidance for skin changes due to chronic exposure to non-ionizing radiation and non-pressure chronic ulcer of skin, not elsewhere classified. And again, those guidance changes, they were one thing, they became something else. So these are revisions, and it is much more, I would feel much better for folks that use these codes to verify specifically how they mean, how they use the code itself. If you're already using it and the guidance has changed, I would much rather you choose those changes. They're difficult to explain without an example. Chapter 13, musculoskeletal system and connective tissue. There are a whole lot of changes. Yeah, there are several pages worth of changes. There are many changes in the tabular addenda, and there are even among those several pages worth of relevant, pediatric relevant codes that I want to call your attention to. Juvenile rheumatoid arthritis has its own code now, a set of codes. So there's unspecified, with systemic onset, other specified site. Juvenile rheumatoid arthritis, I am not going to attempt. I typically am brave enough to attempt, but the MO8.4a is a term that I am unfamiliar with and do not have a guess at. Other specified site and unspecified other specified site. So it's an unspecified type of arthritis, but a specified site that's not listed in the list of available sites that are in this code range. So these are interspersed within the MO8 series. You're going to find these new available options in the MO8s. The M24s also have some additions that relate to body sites. So in general, the addition of specific codes for non-specific sites is what the idea was. I'm sorry, not non-specific, but other specified. So again, in ICD-10 terms, other means you know what it is, but there is no code that describes it specifically. Unspecified is when you don't know what it is. So this was just cleaning up, making complete this M24 series for a variety of derangement conditions that did not have an option for other specified joint. And the same for the M25 series. Other specified joint got treatment for other instability, for pain, and for stiffness not elsewhere classified. There is a set of laterality additions made to the conditions on this slide. So unspecified juvenile osteochondrosis, juvenile osteochondrosis of proximal tibia, of tibia tubercle, see where I get on that one, and other juvenile osteochondrosis of tib-fib. So that's all laterality changes. You now have right, left, bilateral, and unspecified options for this M92 series. Diseases of the genitourinary systems. So these are new codes, and these codes also have been made available in guidance for other codes. So there is a whole host of additions, a whole host of conditions. So that first bullet point is my way of representing that the code series of N0 blank. So that's a placeholder. We can't use X anymore because X is part of ICD-10 convention now. We used to be able to use that as a wild card, but N0 whatever A has been added to a whole host of conditions when there is involvement of C3 glomerulonephritis. So you're going to find a whole lot when you go to look at that tabular. If you've got patients that you need these codes for, you're going to find many, many conditions that now include options for involvement with that C3 glomerulonephritis. The N18.3 series is simply staged. So chronic kidney disease now has new codes that relate to the stage of disease. So stage 3 unspecified, stage 3A, and stage 3B have been added to the staging available for that condition. Staying with chapter 14, granulomatous mastitis has been added to, there is a whole series of codes or a set of codes added to help you express laterality for that condition. Having mastitis as a mom's condition, I took the chance because it's in the N category. You very well may either be treating, I don't suspect you're treating moms for these conditions. More often than not, I see folks refer moms back to their OBGYN or to their PCP for treatment of conditions like this. But this is not, you've heard me say before, the O category or the O chapter is not for babies. This is also not for babies. This is intended to treat the woman who's experiencing this, the patient who's experiencing this. So beware that possible misunderstanding. And speaking of which, remember, chapter 15, pregnancy, childbirth, and preparing, the letter O chapter is for the mom alone. These codes should not ever be used for babies. I do not cover them. Certain conditions originating in the perinatal period, however, we do cover. And earlier in the presentation today, the neonatal cerebral infarction, this has been added. It was in earlier slides, it was mentioned in the context of being added to guidance for conditions related to this. And the laterality is what's been added here. So not only was the condition added as a codable condition unto itself, but laterality was included to create all 4 of these new codes. Chapter 17, congenital malformations. There's guidance for cleft lip and cleft palate that changed. Robbins syndrome used to be completely excluded. There was an excludes 1, so it was intended never for Robbins syndrome to be coded alongside any of the Q35 through Q37 codes, and that has changed to typically not. So the difference between those excludes 1 and excludes 2, excludes 1, you never bill these together. Excludes 2, it's not typical to bill these together. And if you do, they're probably unrelated to one another, but they are not mutually exclusive. It's not a case where you couldn't have both. It's unlikely, but you could have them. That change was made to the Q87, to the Q35 through Q37 series. And getting ahead of myself. Come on. Oh, for heaven's sake. Computer, run away without me. There we are. What is deleted this year is Q51.20, other doubling of uterus unspecified from the congenital malformations. Those have been broken out and made more specific. So the Q51.20 is gone entirely. You would replace it with whatever the meaningful replacement is, whether it's a complete doubling, a partial doubling, or other and unspecified doubling. Chapter 18 is that those ill-defined conditions was the ICD-9 terminology, but this is symptoms, signs, and abnormal clinical and lab findings, not elsewhere classified. So this is that catch-all of symptoms, conditions, things that don't fit into another body system necessarily. They are an experience mostly, not so without the cause or without a condition known. And headache. I know a lot of practices do diagnose headache. And until you know what it is and what it's from, headache is the proper diagnosis. Without the known cause, you for sure can use R51. What changed in this case is, again, it was a switch of an exclude where atypical face pain, migraine, and trigeminal neuralgia went from being you would never bill those or never code those with headache to being there might be cases, an acknowledgement that there are cases where you might bill face pain, migraine, or neuralgia with headache. So they lessened the grip on that one. Continue. I have to stop using my mouse. There we go. So in addition, there are new headache codes that have been added. So that R51 series was expanded to include headache with orthostatic component not elsewhere classified. And R51.9 headache unspecified was revised to put that to places that R51 itself, let me make sure. Yeah, R51 itself, without the additional specificity, does appear in guidance for a lot of other codes. And what this did is the revision of R51, the addition of R51.9 was just another one of those guidance loops that was closed. There are lots of revisions that replace R51 in the guidance statements that it's part of to replacing it with R51.9. And randomly, R74.01, elevation of levels of liver transaminase levels is an addition. That is a new code available for use this year. So lab findings. Continuing into chapter 19, injury, poisoning, and certain other consequences of external causes. It is 2 o'clock, so I want to be sure that I let folks know that I'll understand if you have to disappear. I apologize for getting started late. I have just a bit more to go. And again, those last 2 chapters I want to cover in much more detail next month. It's well in advance of and in time to use those codes for October 1st. But this is the last one, the last ICD chapter that we'll cover today. S20, the contusion of the front wall of thorax got a whole lot of love as far as new codes go this year. There are contusions of bilateral front, middle front, bilateral back, middle back. So as you look through these, you'll notice that the differences are the type of injury and bilateral front and middle front. There are several pages of them that I detail here. Abrasions. So what did we start with? We went with contusions to unspecified superficial injuries to abrasions to non-thermal blisters to external constrictions, and all of those now have front wall and bilateral front wall and middle front wall options. So that was a laterality labor of love, it appears. Superficial foreign bodies, it continues on, it goes on. Insect bites, other superficial bites. So you can see there are several pages of that. Injury, poisoning in the T section here, poisoning by other synthetic narcotics. Again, we discussed a bit of this in the table of chemicals and drugs, chemicals. So some of these concepts should look familiar. Intentionality, whether it was accidental or intentional, poisoning or self-harm. So the intent, who perpetrates it, all those things are included in these new these deleted codes here. So the T40, this T40 series was deleted and was replaced by, so this is synthetic narcotics. What it did was bust out into specific descriptors. So that whole T40 section now, synthetic narcotics, became also known as fentanyl or fentanyl analogs. You've got, so there's a different version. So for fentanyl, for tramadol, and for other synthetics, you've got a separate T40 section. So those are broken out into these specific substances, and additions are made to the complications of corneal transplant to include laterality and whether the complication was a transplant rejection, failure, infection, or other. So those are codes that you guys use. You've got a heads up that there's some additional information and possibly some different mapping that you want to do. Again, these last 3 chapters we're going to feature next month. Those are the all-important Z codes. There are a handful of pediatric BMI changes that I want to get into, and I want to do those properly. I want to make sure that we get those concepts down. I want to remind everybody that SNOMEDMap is a program that is available on all of your systems. And in addition to these top 4 entries here, we've been doing this since 2017. When we introduce the updates to ICD-10, we also make an addition to the top of this mapping report. So when you run SNOMEDMap, and the blue link at the top of this slide will take you to the learn.pcc.com article on this program. This is a partner program that features for you, and I hope I have an example here. I do not. What it does is it features for you when you run this for 2021, it's going to take a look at your EHR. So if you're partner only, or if you're not using PCC EHR, this won't be as meaningful for you because it makes a comparison between your EHR and the new codes. So it takes the favorites that you use in EHR, your favorited SNOMEDs, and it identifies for you whether any of those favorites are mapped to a deleted or a modified ICD-10. So it gives you a heads up, and then it puts it in order of how frequently you use that SNOMED. So this is an awesome report that gives whoever does configuration in your practice a heads up about things that need to be mapped in advance of October 1st. Again, the mapping that's available to us is not detailed or extensive enough for us to reliably choose perfectly matched ICDs for all of the SNOMEDs. They are, for some conditions, SNOMED is very, very different to ICD-10. So we do our best to identify those for you and at least give you a heads up about which ones will appear to be unmapped or improperly mapped as of October 1st. So familiarize yourself with that in advance of October 1st. These next few slides are, as I said, I think I said earlier, the table of contents for the last few months of the AAP Coding Newsletters. I absolutely recommend you take a look at these to familiarize yourself, if nothing else, with their COVID resources. They've got a ton of great articles about COVID-19 coding. They are going into great detail about the E&M 2021 changes. So in addition to the CPT changes that will happen on January 1st, 2021, there are significant changes to the way your clinicians will level their E&M services January 1st and beyond. I will be doing education and coding around that as well, but there is no shortage of great information in the AAP Coding Newsletters. If reading is the best way that you learn, you've got a great resource there. And just as a reminder, these coding newsletters are available at community.pcc.com. So if you have a login there, you can see the link to get you directly into the coding newsletter archive. And when you're in PCC EHR, when you are in a patient record, when you choose the patient education drop-down from reports, that is also a place where you can access these newsletters. So quickly, again, these are all in the slides that I'm going to make available when we're through here. More coding updates, TRICARE changes, more Office 2021 changes, osteotomy changes, Modifier 25 articles, all kinds of great stuff. More E&M 2021, modifier exploration, and coding level 2 visits. I have yet to read that article. I'm interested in that one. I've been so focused on the difference between 213s, 4s, and 5s. And of course, there's always the coding challenges, the questionnaires, the quizzes that can get you AAPC credit. You've got a free half credit available if you are an AAPC certified coder. And a quick run of what's going to happen for practices in PCC EHR practices on Sunday the 23rd. If you are not one of our beta testers, and actually maybe if you are our beta testers, there may be an update for you as well. But everybody, when on August 23rd, this Sunday, will receive the new update. And the very top of this this slide should say 8.13. It is not 8.10. That would be a backward slide. It is PCC version 8.13 that we will deliver unto you in the wee hours of Sunday morning. And the things that you can look forward to in version 8.13, which is right on this slide, there are telemedicine payment parity reports in the dashboard. So you'll see whether your practice, your carriers, how well they're paying for telemedicine as compared to face-to-face medicine. You can schedule appointments for siblings. That's coming Sunday. That is a very, very popular improvement that we've made. Posting hospital and administrative charges will be possible in PCC EHR. It remains possible in Partner, but as we make the slow march toward putting everything in the PCC EHR and the graphical side of things, that is the next addition, as well as time of service discounts. So those two things are billing functions that your billers can take advantage of in the graphical, colorful side of things. You can, clinicians are very excited about being able to mark ERX allergies and medications as reviewed right in the visit history. So when you're reviewing drugs and allergies in an encounter, there are buttons right there in the encounter to mark those reviewed. It has been a very popular time saver for clinicians. Clinicians who use Pocket PCC may now perform signing tasks in Pocket PCC. They can sign documents and orders, I believe. Don't quote me on that, but the learn.pcc.com article has it all detailed there for you. The biggest, okay, that's pejorative. Another very big advance is being able to generate laboratory and radiology requisitions right from the EHR, and they're populated with the important details from an encounter that you need on a requisition like that. There's a tiny bit of configuration that needs to be done, just linking laboratory facilities. And if you are in a multi-location practice, there's a bit of work to be done there. So please reach out to your CA if you have not been contacted already. QBCDE, the query-based document exchange. We are now in the initiator phase. So before we were able to respond to queries from entities outside your office with that standard query-based clinical document exchange answer, we could answer those queries. Now we are in a pilot to initiate those. So not everybody will get that on Sunday. There are folks that are already piloting that for us, but this is just a point of awareness. You will, after Sunday, be able to schedule reports in the EHR to run on a recurring basis automatically. So it's a set it and forget it kind of thing. You can set up a report that you like. If you want to come in on the 1st of every month and find a particular report has run and not redefine it each month and not rerun it each month, you can do that. There is a new provider utilization productivity report, as well as a new provider breakdown for immunizations. And I believe those are both in the dashboard. And I have completely used up all of my time. This is typically the time in the hour and when I open up the floor to billing questions, and I'm happy to do that. Like I said, I recognize that folks are, I'm well past the hour that I promised this would take, and we'll tell you that our next session is the 15th, Thursday, September 15th at 2 p.m. It will be a practice management web lab. And this is just how to get in touch with me. So if folks do want to stick around and do have billing questions that you wanted to crowdsource or pick each other's brains about, please do go ahead and do that. I will open up and unmute everybody. And if you have questions, have at it. Look at that.
Oh, wow, that's a great. You're gonna do